As Dr. Aberbach said, we're here to take a short journey into to medicine, and I'm not sure I can tell you exactly how doctors think, but I will actually tell you that at present, the way modern medicine has evolved, the authority of medicine doesn't really lie with doctors anymore. So in many ways, your doctor is simply someone who is your conduit into this system, which is really what we're going to be talking about today, because it is that system which has evolved fairly far away from the patient, which of course most of us as patients find difficult. So I'm going to start with a very brief history of medicine. No, I'm not going to go back thousands of years to the Greeks. I'm sure you can all sort of read up on that if you're interested. But I'm going to take us back to the 19th century, which is really where modern medicine began, or what we call modern medicine. In everything else, we're postmodern, but in medicine, we're still modern. Medicine in the 19th century took a huge leap forward, and this was largely because the other sciences had moved so far forward. There were developments in chemistry and in bacteriology and in all these other areas, which of course blended and came together to push forward medicine and the concepts of medicine and so on, and it was a very exciting time. The late 19th century was essentially what we call the dawn of the modern era, and it was a time when anything seemed possible. It was a time when people were hankering back to the Enlightenment and the idea that human beings could reshape and create their environment using science and technology, and that progress was possible, that moving forward was possible. So of course science played a big role in that, and medicine moved forward with people like Louis Pasteur, who gave us pasteurization and who made us realize that there was no such thing as the spontaneous regeneration of organisms, that when you left the meat out and there were maggots and things on it, that these hadn't spontaneously developed through the air, through the ether in the air, that there were bacteria on that meat, which subsequently fed these little microbes and these various microorganisms. The other area that really went forward in the late 19th century was immunology. And it was that first idea that we can understand the physiologic workings of the human body. And that was very exciting because at that point, anatomy had been understood. And over the years, through all of the illegalities of cutting up people, so they would cut up pigs and they would cut up animals and they would steal corpses from cemeteries, or do all these fairly nefarious things to try and find out what we were like inside. And it was in many ways the era of the Germans, because we have two very big names, Paul Ehrlich, who won the Nobel Prize at a certain point, and who originated the idea of chemotherapy, and the idea that certain tissues in the body were sensitive to certain substances, which led him to discovering what was called salvarsan, which was an arsenic compound that was a treatment for syphilis, which at the time was a very big deal. It still is, actually, but with antibiotics we're not as concerned about it. But at the time, syphilis is a really nasty disease. It ends up in dementia and madness, and it's a horrible, horrible illness. And a lot of people had it. And Ehrlich also was the first person to recognize that there might be such a thing as an autoimmune disorder, that the body might actually turn on itself, which he called a horror autotoxicus, which at the time everyone thought was absolutely mad. I mean, it was just not possible. How could the body turn on you? It was just not possible. The other big name was Koch, and from him we got Koch's postulates. I never know how to say that. K-O-C-H, and Koch sounds a bit wrong. So essentially, Robert Koch, he was also another German, and he identified the tuberculosis bacterium, and he identified the cholera vibrio bacterium, which again led to the understanding that a bacterium could actually within an individual cause disease. Now, we had known that that dirty water caused cholera for 200 years because John Snow had discovered in the Broad Street pump that when there was fecal matter in the water, that people were dying of cholera, but they didn't really know why that fecal matter was causing the cholera. And Koch identified the cholera bacterium. So you had all of these ideas essentially moving forward. And in addition, of course, you had war. And war has always been very, very good for medicine. It has also been very good for accelerating the pace of medicine. Things, ideas, discoveries that are on the back burner when there are wars and people who are hurt, people who need care, then these things get moved along. Now, at the end of the 19th century, of course, there was the Boer War and Florence Nightingale, and she wasn't just a really good nurse. She understood ideas like hygiene and sanitation. She was also very good at understanding the idea of public health and using statistics and graphs and so on to convince the authorities that perhaps something needed to be done. Some years earlier, Lister, who was a Scottish physician, had realized that antisepsis was important because people were dying in droves whenever they tried to do surgery. And he realized that it was, in fact, the filth that was the reason they died. But it really wasn't till the Boer War and Florence Nightingale that most of these ideas took hold outside of that very narrow area where the person who originated it. As I said, war has always been very good for medicine, all the way back to the Trojan War, which gave us pain relief, analgesia. The Napoleonic Wars gave us improved surgical procedures for things like amputation. The Napoleonic Wars gave us triage and ambulances. The American Civil War accelerated the acceptance of anesthetic, which again had been used, but in only small, small places and in very slightly. And then there was the First World War, which was, as you all know, a very, very horrible war. And there were treatments which were improved for burns. Plastic surgery was somewhat improved. Blood transfusions were brought into common practice. And there was a somewhat better understanding of the psychological effects of war, of battle fatigue, post-traumatic stress, and so on, because obviously that was a war that led to many, many people having, many, many soldiers essentially being very maimed after that war. And then, of course, there was the Second World War. And the Second World War was the best possible thing that could have happened for medicine, at least modern medicine as we know it. Because the Second World War accelerated the development of antibiotics. And in many ways, antibiotics are what have made modern medicine what it is today. Because antibiotics gave us the idea, the concept, the belief that we can actually fix something, that you can take a medication, that you can do something, you can take a drug, and quite magically, if it's the right thing, you feel better. And you get well, and you don't die. You don't die of TB. You don't die of various and sundry things. But more than antibiotics, World War II accelerated the idea and developed the idea of technology. Something that has started in the 19th century, that science and technology and progress, and things had kind of grumbled along for a while. But what happened after the Second World War, during and after the Second World War, with that massive acceleration of technology, of airplanes, of radar, of all sorts of things, which I cannot possibly begin to tell you about because I don't know. We would have to ask Dr. Aberbat. But essentially, medicine essentially came along with that idea that technology was the answer, that the solutions to illness, the solution to disease lay in better technologies. And those technologies were not only medical, they were also administrative. And one of the, and essentially conceptual. So what happened at that time, in addition to the development of antibiotics and the use of antibiotics, antibiotics, as you know, were discovered by Fleming in his laboratory in 1938, but didn't really make it into common use until the war, when a small amount was synthesized. We had known for easily 50 years prior to that there were substances that killed. Am I making funny noises now? That we knew that there was something that killed bacteria. That's why we called it antibiotic. It's from the word antibiosis. Romany women in the east of Europe used to use cabbage, rotting cabbage, and they used to put it on wounds, and they would find that it would heal. But what Fleming did was he found that it actually worked on human tissue. And because he had been working on lysosine, which is a substance that comes out of the eye and nose, and that was the material that was in his beaker, and which the penicillin killed. And over the next roughly decade, two other scientists, Florey and Chain, synthesized penicillin, and the three of them shared the Nobel Prize as a result. Now, when penicillin, or initially streptomycin, became available, there was I feel like I'm walking around in a spacesuit here. The first clinical trial was a result of that, of both the antibiotic being found and of the Second World War. And a gentleman by the name of Bradford Hill, who had wanted to be a doctor but had had TB as a youngster, and therefore couldn't become a physician. I guess he was a bit fragile. So he became an economist instead. And he felt that medicine needed to use statistics better. Medicine needed to test its interventions better. And so he convinced the Medical Research Council in the UK, which had been given a very small amount of streptomycin to treat people with TB. He convinced them to allow him to set up a clinical trial. And it was very small because they only had a tiny amount of streptomycin, about 100 people. And what he did was he split up those 100 people, two groups of roughly 50. To one group he gave the streptomycin, and to the other group he gave a placebo. And what he found, not surprisingly, was that the streptomycin worked better. Although in the placebo group, who got bed rest alone, of that 50, 13 people actually got better. So it's not like everybody in the non-antibiotic group died and the other group all got better. There was actually some variability there. And even then, there were some toxic side effects, and there were some bacteria that became slightly resistant to the streptomycin. And so Hill actually did realize that this randomized clinical trial, in which he wanted to use statistics to evaluate medical interventions, had its downside. Unfortunately, as time progressed, we have not all been as wise as Bradford Hill was. So the clinical trial, as any of you who read newspapers or anything, has become very much the gold standard of evidence in the present day. And this is where it came from, this whole idea that you must use science and technology to test your interventions, and that people other than the doctor and the patient need to be involved in this process. Because prior to that, when medicine really couldn't do very much, really nobody wanted to be all that involved, because really the doctor came and gave you some kind of potion, and it might work, it might not, and he would tell you to rest and so on. And they did a couple of things that, they had opium and a few analgesics that worked a bit, but by and large, medicine wasn't able to do a huge amount. And so the doctor-patient relationship was left alone. But with time and the increasing complexity in what became available, all kinds of other people became involved. And we have health economists and administrators and politicians and various and sundry people. And what we saw over the last 20, 30 years has been really a confluence of these people, of these groups, of these people who have become involved in medicine. How did we really become quite so engaged in this statistical and so on? Well, part of the issue was the ascendance of the Americans after the Second World War. Europe was in tatters. The rest of the world was falling apart. A lot of countries in Africa and so on were trying to come out of the their colonial yoke. And so America was it. And America has a very specific culture of its own. And people think that medicine is somehow, or science is somehow above the fray. But that's not true. Everything we do is connected to how we think and who we are. And of course, who we are is also related to our society and our culture and everything around us. And Americans from way back when have always felt that they were stronger and tougher than everybody else, and that their diseases probably were stronger and tougher as well. And in fact, Benjamin Rush, who was one of the signers of the Declaration of Independence, actually, and he was a physician, felt very strongly that American diseases were nothing like those effete European diseases that people in the old world suffered from. American diseases were tough, like the Americans, and they needed tough treatments. And he had developed this idea partly because he had treated yellow fever. And subsequent analysis suggests that the people he actually treated with these very strong purges and extreme bloodletting techniques really didn't have yellow fever to begin with, which is why they eventually got better. But he became quite convinced that these very strong measures were what needed to be done. And so even now, if you compare ideal dosage of something very simple like aspirin or Tylenol in the United States and Canada, because we tend to cleave to the US in this, and if you compare that to, say, France, the maximum recommended dosage of Tylenol in France is about a third of what it is in North America. And if you go to a pharmacy in France and you say, I have a cold and I really need some, something to help my cold, and you say, oh, and I've got this headache, so could you give me some Tylenol? And they'll say, you're not taking these two together, are you? Because this one's got Tylenol in it, and you're going to overdose. And so there's a real fear that you shouldn't take, of this notion of overdosing. Whereas in the U.S., the idea and Canada, as I say, because we have very much tended towards the Americans when it comes to our drug therapies and so on, we tend to give higher doses, and we tend to do more surgeries, and we tend to, generally speaking, be more active in what we do. Canada, of course, because we can't afford to do as many surgeries and so on as the US, we do fewer. But it isn't necessarily for want of trying, as again, anyone who reads all the stuff about medicine and Medicare in the newspapers knows, because we're always complaining that we need more and that we don't have enough. We need more MRIs and more surgeries and more. We always need more things. And again, it's that idea that more is better, that the more you do, the better it is. But in reality, medicine doesn't actually work that way. Medicine actually operates on the notion of on the law of diminishing return, I think it's called. And it's that paradoxical notion that the more you do, the less useful it becomes with time. If you look at medical errors, for example, nearly 70,000 people in the acute care setting in hospitals in Canada suffer from iatrogenesis, in other words, medical mistakes. and 20% of those people die. Now, this doesn't mean that acute care hospitals are dangerous places, because usually if you end up in an acute care hospital, there's something wrong with you. But what it does mean, as public health people have noted and written about and so on, is that once you get into that environment of the hospital, there is essentially a therapeutic imperative. Things happen to you, and sometimes they happen by accident, or sometimes they happen because you get sicker. But what happens is you are in an environment where there is care, where there are doctors and drugs and surgeries and all sorts of things, this is what the purpose of the hospital is. So you get into that hospital with something that's gone wrong, and if something else happens, then they have to treat that, and something else and more. And eventually what can happen is that you can no longer take that. You know, your body essentially gives out. And it doesn't really matter how old you are or who you are. There are some things that people simply can't take. And the medical errors are a huge issue, and for a few years ago they made headlines a great deal. They've sort of fallen into disregard a bit at the moment, but the fact is they do happen. And some of it is somebody's fault, but some of it really isn't. It's simply that, let's take a cardiac catheterization. It's simply considered a test. You know, they want to check what your heart does. But what they're doing is they're essentially taking a tube and they're sticking it into your heart. And it's very easy for that tube to essentially nick along or essentially do something. So there are Mammograms where they inject these dyes. Well, about 3% of people are massively allergic to those dyes. And we don't often know ahead of time who those people are. So whenever there is, you want to do a test, when people want to do something invasive, it really behooves you to ask, how will this change the clinical picture? Because sometimes there is no reason to know something. I had a friend years ago, late friend actually, who was a very good patient, and he did everything the doctors told him to. And he by the time he hit his 50s, he had various and sundry things wrong with him, and certainly I don't blame anybody for it, but there was always this sense that, well, we don't really know why you're so ill and why you're not gaining weight, and so there was this test and that test. And then they would say, well, okay, well, we need to see, you know, obviously your heart isn't working fine, but we can't figure out exactly where or why. And I said to him, well, ask them, how will this change the clinical picture? Will this change the treatment? Will this change what you're going to do? How will this change anything? Because if all you're doing is going in there in order to see what part of the heart isn't working perfectly, which you haven't been able to see with your echoes and all your other ones, which with the slightly less invasive ones, who cares? What difference does it make? Because ultimately, when it comes to physiology and essentially what is your body, knowledge for the sake of knowledge is really irrelevant. Because when you can't do anything for something anyway, what difference does it make what it looks like? And but especially when you go up the scale to the specialties and subspecialties, often people have fellowships, and again, I absolve these people of any malice, but they often are academics as well as occasional clinicians, and they're very interested to know why these things are happening. And yes, perhaps in the long run for someone else their knowledge might be useful, but personally I don't want to be the guinea pig, particularly if I'm not feeling well and I'm ill and I'm feeling a little fragile and so on. So that unchallenged therapeutic imperative, as one public health person calls it, within acute care settings, which push people up to increasing levels of care, often end up having problems with them. So this is probably why doctors just hate going into hospital, and they do everything possible to leave. But as I said a minute ago, the paradox of medicine is that a little bit is good, but too much can be very harmful. And this is actually true in a grander social setting as well. There are two competing views of health. The subjective one, how you feel, how I feel, and then the objective one, the external one, the tests, the scans, the what essentially is not you. So I don't feel so good, and I go to the doctor, and I say, you know, I got this pain over here, and well, of course I got a pain. I've got all these things hanging on me. And I'm a little concerned, and so he sends me for an ultrasound and this, that, the other, and it comes back, and they say, well, there's nothing, you know, we didn't see anything, you're fine. And I say, yeah, but I still got this pain over here. So that sense, that subjective sense, which is I say I have something or I don't have something, and that objective, these are these two competing views of health. And it's interesting that often our internal sense in a social sense does not correspond with what the actual healthcare environment is. A very well-known Nobel Prize-winning economist by the name of Amartya Sen, who actually died, I think, a couple of years ago, and I recommend reading his essays and so on. He's a lovely writer. And he actually did a study in two counties in India. And what he did was he compared the state of Kerala, which has the highest literacy and longevity rates in India, and also has very good health care for the region, and he compared that with Bihar, which is apparently a very poor area, and the medical delivery systems are woeful. And what they did was they actually asked individuals how well they felt, how healthy they considered themselves. And interestingly, in Bihar, where there was hardly any healthcare, and everyone said, oh, I feel great. And on essentially normative values of health, they rated themselves very high. Whereas in Kerala, where they were very literate and they had good healthcare and so on, they all said, oh no, I do terrible. Oh, I'm terrible. I have all these things wrong with me, and I can't get that doctor to get me in. I can't get the medication I need. So ironically, in North America and in the West, to some extent, we have fallen prey to that exact issue, which is the more we have, the more healthcare there is, the more we have available to us, the more we read about medicine everywhere we go, and the more little sort of bulleted things that we find in magazines about this test and that, the more deprived we feel. That somehow we're missing out on all of these really great things that aren't being done. Well, you laugh, but if you pick up a newspaper or if you watch the news, there is this continual moaning about how bad Medicare is becoming, and wait lists, and how dreadful. Somebody the other day, an acquaintance of mine in Toronto, who I had thought to be a perfectly sensible human being, sent me a YouTube thing the other day. And he said, oh, you'd be interested if this is about medicine. So I thought, okay, and I started to watch it, and it was something about this couple in Ontario and a broker they had gone to see who had got the man down to Buffalo for his MRI because this fellow had headaches, and they thought it was a brain tumor, and there was going to be a 3-month wait for him to get to his MRI, and they were absolutely furious, and the wife's father had just died, so they could afford it. And so they went racing down to Buffalo, and this broker who was being interviewed was saying, and it was a class 2 astrocytoma, which is cancer. If it had been a class 4, I mean, think of how often. And I thought, yeah, if it were a class 4, MRI or no MRI, he'd be dead. So what exactly did the MRI do there? So if he had been really bad, if his behavior, his headaches, et cetera, had indicated, I'm sure, to the physicians that he really needed this MRI, he would have been sent to the head of the line. But as it happened, waiting 3 months for something that isn't necessarily necessary is not that big a deal. And we used to understand that, but we don't necessarily seem to. I think there is also this real thrust at the moment in terms of right-wing governments and insurance companies and so on, who are constantly telling us that we deserve more than this. But there's a very odd idea around screening. We seem to think that screening is an intervention. Screening is not an intervention. If screening actually cured anything, then Röntgen's X-rays, which were also developed in the early part of the 20th century, which identify pulmonary tuberculosis, would be a cure for tuberculosis. They're not. Streptomycin was. So simply looking at somebody's lungs and saying, oh, look, you got these stripes there, which means you might have TB, is really not anything other than giving you information. In certain instances, of course you want that information. Before your neurosurgeon goes in to get that, astrocytoma out of your brain, you really would like him to know where it is. So he doesn't, go off and he doesn't go on the other side of the brain. So there's certain areas where of course you want these. But one of the largest uses for MRIs at present is for joints, is for knees in particular. And when you talk to anybody who's in orthopedics, what they tell you is that, well, when you fall or you do something to your knee, when it first happens, there's no way of knowing what it's going to need, because sometimes terrible things get better and sometimes the ones who aren't so bad don't get better and they end up needing surgery. So you have to wait. You have to wait a few months and take those anti-inflammatories and do the physio and put the hot packs on and do all those things. And if it doesn't get better in a few months, and you really are very distressed about it because you can't go play your golf or do whatever, lead the kind of life you would like to lead, then fair enough, we will do an MRI and we can, but even then that MRI isn't necessarily what you need to do, because why not just go straight to surgery? Because if it's lasted 6 months and it's not getting better, then you're probably going to need the surgery anyway. And knees are not brain tumors. It's not that essential. They're not that different. They all pretty much look the same. So again, that notion that we have to know what it looks like. But is it really us who want to know, or is it that we have created a culture which is very, which is fascinated by all this? And then we have the makers of these technologies who are in the background. I mean, I don't know who makes MRIs. I doubt anybody here does. But I'm sure they have PR departments just like everybody else. And I'm sure that they're out there, talking to the physicians who think the technology is great. And the more we talk about these things, the more it seems that, well, they're simply part of, what we do. And even CT scans and MRIs and X-rays and so on have risks. Now, I talked to you earlier about cardiac catheterization, which has very real and very potentially fatal risks. Not in many cases, particularly if the person doing it knows what they're doing, but the risk is there. But even a CT scan has 4 to 6 times the amount of radiation that an X-ray does. But we don't really think about that because, I mean, X-rays, your dentist wears that, armor and goes behind the wall, and they're like, oh my God, it mustn't get near you, unclean. And you go into a CT, and there's everybody wandering around, and they stick radioactive dye in you, and you feel like you're going to explode. I've only had one once. And nobody thinks twice about the amount of radiation that's present in a CT scan. So MRI, I don't know, but it's a magnetic resonance imager, and you cannot go in with any metal whatsoever, and metal will go flying around the room. And I recently read that people who have old tattoos, which have some metal in them, actually can find MRIs very painful because it pulls at the metal in the old ink. And I don't really know whether this is bad for you or not, but it stands to reason that something that's going to make your watch fly over there and hit the ceiling is probably having some effect on you. And again, this isn't to say they shouldn't be used. Of course, they're very useful, and they have functional MRIs which actually show how things in movement. And under certain circumstances, these are extremely useful when there is something that is a tumor or something that is very, very hard to identify otherwise, and which is potentially treatable. But we mustn't take these things lightly. Everything has risks. Interestingly, we don't talk very much about the risks of screening and so on, and yet risk factors have become a major issue in medicine now. And that's the next thing I'm going to be talking about, and that is in fact part of the cautionary tale, because risk factors, as perhaps some of you remember, really didn't exist 40 years ago. Nobody talked to you about the risk factors for heart disease or the risk factors for various and sundry things. Those were actuarial terms. The insurance industry used terms when they were trying to insure you, when they were trying to decide how much money you should be paying in order to have life insurance or term insurance or whatever you were trying to get. But what happened in the 50s, again, after the Second World War, in the 50s and 60s, was that this idea of risk factors came to the fore partly as a result of the Framington longitudinal study, which was started in Massachusetts in the late 1940s. And I don't know a huge amount about it, but essentially a group of researchers decided that they really wanted to see what would happen to I think it was the entire town actually. So they decided to just simply follow this group of a few thousand people, I think. Again, don't quote me, I don't remember the exact details of it. And they're continuing to follow, they're still following them. And so they measured things like blood pressure and various and sundry things. In terms of cardiac, the other thing that happened was that the American Heart and Stroke Foundation was formed. After the war, a great many other administrative functions came to the fore in addition to the randomized clinical trial. The FDA, for example, essentially was formed. And the idea that we needed to test drugs, that we needed to approve drugs, all of this previously anybody could give you anything and call it anything. But there was that notion that we needed some control over these medications and so on. And so the FDA was formed. A few years later, Health Canada was formed. And so we started to examine how things worked. And again, there was an institutionalization, this codification of how things were, how medicine was delivered. And the Heart and Stroke Foundation, like the March of Dimes, as it then was, were trying to create roles for themselves. These were organizations, these were charities, and they wanted, like everyone else, like any other organization or institution, to have adherents, to have some money, to have some power and control and so on. So they started raising money and they started funding research. And what they found in the 60s was that people came to them and said, well, okay, we're giving you this money, you're funding this research, but we never hear about it. And they thought, oh, okay, well, maybe we should be actually publicizing some of this, because we've got some bits and pieces here which might be of interest to doctors and patients and so on. So they tried to come up with ways in which to communicate this information. And risk factors developed out of that. But bear in mind that here you are, here I am, the patient, and there is your doctor. But then you have got the people writing these things, and then you've got the Heart and Stroke Foundation, and then you've got behind them the researchers. So at every step of the way, things get rounded out, and things get simplified, and things become a little, because anyone who has read basic research knows that, you know, you read the methods and there's this and there's that, and it might be this and it might be that, and there's all there, the raw data is really complicated. And then somebody writes about it in much more, in much nicer terms where you can understand it, and they essentially simplify it for you. But at every step of this process, information gets lost. And to some extent, if we want to use the word truth, which I don't like to, but you can argue that a certain amount of accuracy certainly gets lost. So by the time this information is essentially sort of put through this blender for you, and it comes to you in this lovely cup, you know, with pretty orange juice or what have you, all of the nice fiber and all of the intricacies and all of the complexities, the questions have been lost. And even if we consider, even if we allow that those research scientists did a superb job and it was superbly communicated, and all of that was done in just wonderfully. The fact remains that a clinical trial, a study, is never really an indication of what will happen, what happens to the population at large. It is at best an ideal situation. What it is essentially under a very specific set of circumstances, when a certain treatment or a certain drug was administered, then this happened. But women were hardly ever in clinical trials because they had hormonal shifts, and this could screw up drug results. And also they could get pregnant. And if you're testing a new drug, thalidomide was still on everybody's mind. And so what if it causes birth defects? What if there's a problem with this? So women as a rule, and their cutoff dates, ages, where by and large 64 is the highest that people are allowed into clinical trials. Usually it's younger than that. Usually it's 59. And so what we're essentially saying is that primarily youngish men with, say, a certain kind of heart defect, who were given a certain kind of medication, appeared to achieve some benefit from that. Well, does this actually, does this apply to you and me? Particularly if we're older and we have other things wrong with us, and we've got a touch of diabetes, and we've got arthritis, and because the other thing about clinical trials is they don't want their information messed up with comorbidities. In other words, they want people who have one problem. They really don't want to have people who've got 55 different medical issues. But the reality is that most people who take medication are somewhat older, or if they're not older, they have chronic illnesses, which means they've got more than one thing wrong with them. And so right there, you're getting into very, very shady territory. Now, I'm going to finish off in my last 15 minutes with the cautionary tale part of how Dr. Aberbach introduced this. And I don't have time to get into huge amounts of detail, but I'm going to try and instill in you an enormous fear and terror about all kinds of things. And with luck, inspire you to go out and do some reading and do some research of your own, because there are many things which are presented to us very authoritatively now. And not just from the medical perspective, but they are presented in newspapers and in magazine shows, on television, and even in fictional shows. I mean, if you watch ER or House or what have you, there is this wonderful heroic role assigned to medicine. And yes, and Dr. House. And medicine comes leaping in on its white charger. Now, House, in all fairness, because they've got those other fellows who are out there going, hey, you could kill the person with that, does at least occasionally point this out to you, that some of these things are very, although I do remember there was one about a year ago where there was some weird and wonderful illness, which I actually went and looked up because I wasn't sure what it was. And when they discovered what it was, House said, start the treatment. And I thought, what treatment? And I went and checked, and there is no treatment. It's this terrible illness which basically has no treatment. I mean, you can treat a few of the symptoms here and there, but he just said, start the treatment. And I thought, okay, well, that's I hope nobody who has that particular illness was watching this, because they're going to think some marvelous change has occurred. But there is an enormous authority about medicine at the moment. And your grandmother, my grandmother, knew when she was sick. She didn't have to be told not to overuse the emergency room. When she was sick, she went to hospital, or she went to the doctor, and the rest of the time, most of the time, she didn't. Now, it's not uncommon for any of us to go in because we have a complaint. We've got a really bad chest, and we think we might need antibiotics, or Or, we hurt our knee and it's not getting better. Anyway, we got something that's worrying us. And that in itself is actually sociologically interesting, is at what point do you decide to seek help? And that is not necessarily personal all the time. It's sometimes other people saying to you, you should get that looked at. Or, I had a cousin with that and she died, And so, you think, oh, well, maybe I should get that looked at. And so you go into the doctor and you say, look, I've got what have you. And well, the doctor says, okay, that's nice. And he says, well, we'll give you some anti-inflammatories or send you for an ultrasound or whatever it is that we're going to do. And then he says, oh, wait a minute, how old are you? Oh, you're postmenopausal, aren't you? Okay, well, have your bones been checked? And have we taken your blood pressure? And cholesterol, have we checked your cholesterol? And, and by the way, why haven't you been having mammograms? Because I cross them out and I tear them out. But, other than that, why haven't you been having? And suddenly, you're no longer you. You're a type. And essentially, this is how I sort of ending with what I began, is what started in the 19th century, went through the Second World War and gradually became codified. And we created these bodies. And some of those bodies are commercial. People say to me when I say I write about medicine, I hate pharmaceutical companies. And yes, pharmaceutical companies, but bear in mind, these are not charitable organizations. And I don't really know why people hate them so much. They can't make you take drugs. They can't come and force it on you. And so you have informed consent. And so, their stated intent is they're a company and they intend to make money. Now, yes, some of them, Merck people, the people who started them were, again, 19th century people. They had a certain amount of social conscience and so on. And some of them, they still spend a little bit of money on, various and sundry things. But ultimately, these are companies. Why are we expecting them to do our research? Why are we expecting them to tell us what the really dire consequences of their drugs are? We're the ones who should be doing that. The governments, the universities, the academies. And we have absconded, essentially, that responsibility, and we're furious at the drug companies. Now, having said that, the drug companies have done some, they spend a huge amount of money on marketing, and they do a great deal to try and persuade people to see their doctor about these, ephemeral symptoms. Now, in Canada, those ads are illegal, but we still get them from the U.S. And we see it all the time. Is, have you got these, rheumatoid arthritis or this or that, the other thing, and check with your doctor. But in that process, what happened, and this codification that happened with all these various groups, including pharmaceutical companies. But we also have people like the Therapeutics Initiative at UBC, which is a group of economists and pharmacologists and I don't know who advise the government, the provincial government, on which drugs to include on their formulary and which drugs not to. These are people who never see patients, who never get called in the middle of the night when a drug isn't working. They never have someone yelling at them because they did the wrong thing, as we do to physicians. These are people completely divorced from the actual clinical encounter and what goes on in that doctor-patient relationship. And all of these groups essentially have, to some extent, a vested interest insofar as Mark Twain said, they are drawing a salary from this. This is what they do. And they have become increasingly authoritative. And where the problem with drug companies really lies is in that conflict of interest, which is very, very hard to see. And that is where they recruit what they call opinion leaders in the medical community. And what they say, because these are physicians that other physicians respect, usually sort of mid-career, or they have a fellowship or what have you. And they sort of identify these people. And they try to get that person to promote their drug. And by promote their drug, I don't mean actually hawk it, but to use it. And to tell other people that it is a great drug. And then they invite that physician to sit on their consensus conferences. They fund consensus conferences. So let's say the Society for Obstetrics and Gynecology, or whatever they're called, has a conference, and a nice drug company offers to give them a fairly large chunk of money so that they don't have to pay for their lunch, and that they get to sit in a bigger room, and they give them a nice little goodie bag, and so on. And then at that conference, what they do is they put together an august panel or a consensus conference, and they come out with recommendations as to what you and I should be doing, whether we should be having mammograms, or whether you should get your PSA tested, or whether we should be getting our bone density checked, and so on and so forth. Osteoporosis, mammograms, PSA testing, colonoscopy. These are the big four that are continually pushed at us. None of them essentially are what they're cracked up to be. Osteoporosis, the bone scans sound very compelling, but there has never been any data linking bone density with breaking bones in osteoporosis. The danger is fragility fractures, is that you do this and you break. That is dangerous. But it's natural to lose bone density as we age, whether we're men or women. And years ago, not that many years ago, but probably about 40 years ago, sodium fluoride was believed to be a real great cure for osteoporosis. And because sodium fluoride does in fact increase bone density. And it was shown to do it in the lab, and it was shown to do it in people, except it increased fractures. By making them essentially stronger, it also made them more brittle. Years ago, I remember getting some kind of hand cream that was supposed to work on your nails as well, and it was called hand and nail whatever, and it did that for my nails. I've always had reasonably good, strong nails, and suddenly they were breaking off all over the place. So things that make something strong are not necessarily a good thing when the real risk factor is the breakage. Mammograms. Everybody, celebrities, women's advocacy, everybody wants us to have our mammograms. Well, aside from the fact that mammograms tend to be very high in radiation as well, there is no evidence that they work for women under 50. There is virtually no evidence that they work for women under 60. And really, if you get breast cancer when you're in your 60s, you're probably going to die long before the breast cancer gets you. And I mean, I'm sorry to be so blunt, but the reality is we all have to die of something. Life expectancy in Canada is 80. If you live to be 85, you've done really, really well. If you live to be 85 and you're healthy, then you are stupendous. You are superb. Don't screw it up. And the problem with going in with what is a mammogram is in essence a very, very blunt instrument. It doesn't know what it sees. It's like an ultrasound. It just sees a thing. It doesn't know what it is. And it also depends on the person reading those mammograms. And what we're finding now is people are being sued more. And interestingly, I was asked to review an article for the CMAJ, and it ended up being rejected, but it had some very good points. And one was where they actually talked to radiologists and so on, and what they found was that the perception of many physicians, this was in Ontario, was that patients will sue you at the drop of a hat. The reality is that the incidence of patients suing doctors, radiologists, what have you, has gone down over the last 10 years. But the perception is that people are ready to jump on you and sue you at the drop of a hat. And so there is over-care. What happens is that if there's any doubt whatsoever in the mind of the radiologist, he's going to say, get it tested out. And physicians on the flip side will send someone for a test of some kind and say, look for abnormalities. Well, the radiologist doesn't know what he's looking for. Chest x-ray, look for abnormality. Is this a smoker? What am I looking for? So communication between physicians, the skill of the physician, and radiologist as a physician, is very, very important. You're looking at, again, just as I said about the research, there are all of these steps involved before it actually gets to you. 10 years ago, something called DCIS, ductal carcinoma in situ, was not considered a cancer. It was simply, it happened sometimes around the milk duct, and they would usually say, well, certain watchful waiting, we may want to keep an eye on it for a time. But somewhere over the last decade, it turned into a precancer and then a cancer, and now it is a full-fledged cancer. I don't think it's actually killing any more women than it used to, but we are now treating it differently. I'm not saying nobody should have mammograms. I'm not saying, you know, nobody. If you have a very strong family history, you probably have the gene, the BCR, whatever it is, 1, 2, whatever it is. And if you know, your mother and your aunt and your sister have all had breast cancer, well, you may want to have a mammogram because you may want to catch that tumor while it is still very small, because in your case, you're probably going to get breast cancer, and you're probably going to die before you're 55 anyway. But at least maybe that will give you an extra 5 or 10 years. But that is a specific illness. Breast cancer is not one illness. As you get older, you are going to have certain can't even talk. Differences in your body. It's not coming. Some of those may be problematic. The vast majority probably won't. And what I say to people, and again, this is going to sound absolutely awful, is if you have cancer, you will know it. The cancer that's going to kill you is going to grow fast. A friend of mine who did have the gene, and although at the time they didn't identify it, she had had a mammogram in April. She was due for her next one in October. She found a lump in August, in between those two mammograms. When something grows that fast, you will know it. And as I say, I'm sorry to be so blunt, but this business of screening, and colon cancer, the same thing. If you have a family history, if there is, but you may want to have not a colonoscopy, a sigmoidoscopy. A colonoscopy and a sigmoidoscopy the difference between them is about 2 inches. Sigmoidoscopy is a flexible tube. A colonoscopy is a stiff tube. Stiffness going up 2 extra inches, your risk of nicks, cuts, bleeding, et cetera, rises commensurately. Sigmoidoscopy, if you are concerned, at least it's flexible, it'll go up, and it will be able to find the polyps that they can subsequently take out. Again, there is very poor evidence showing that polyps do in fact turn cancerous, and it's very hard. That predictive value is not very good. But if you are concerned, and this is what I always say to people, if you are genuinely concerned, absolutely do it. But don't get shamed into it. We're being pushed into doing more to keep healthy when we are healthy. That isn't necessarily the best use of medical resources. So I would urge all of you to be cautious and to ask when they want you to have a test or a scan or some kind of screening what the purpose is and how it will change the clinical picture.